Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we share a beer with Dr. Ashish Patel, the Division Chief of Gastroenterology and Hepatology at Phoenix Children's Hospital, and we discuss treating kids with inflammatory bowel disease, transitioning those kids to the adult care world, the exciting world of pediatric research, and CRISPR. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is your girl, Robin, and I'm joined by
Alicia, your other hanger-on. We are very excited because we're joined by Dr. Ashish Patel. So Dr. Patel, we're going to turn it over to you and then we're going to stop calling you doctor because it's a podcast. First though, we're going to ask you, what are you drinking?
So, hi, I'm Ashish and I'm happy to join you lovely ladies. I am drinking a sweet and sour grapefruit IPA by Untitled Art, bottled up in basically the opposite of where I'm at in Wisconsin. And currently I'm in Phoenix, Arizona, where it's 80 and sunny most of the days. So I'm happy to join you guys. I'm a pediatric gastroenterologist by trade, and I am currently the chief of pediatric GI here at Phoenix Children's Hospital. And I have a long history of working with inflammatory bowel disease patients. So this is a pleasure to join.
You're our first official medical guest because our last person who had a medical, she's a medical professional, but she's also a patient. So you're our first just true medical guest. So we're excited to have you.
Thank you.
Tell us a little bit about kind of why did you choose pediatric GI? Why IBD?
Yeah, so it's funny. I was just doing a capstone course with some students over at University of Arizona, and they were talking about why did you go into pediatric GI? And it's been a long time since I've sort of thought about sort of all of those sort of formative years, but I was always one of those medical school kids that always knew that I wanted to do pediatrics. And then when I got into residency, I got really first time exposed to GI, and I was just really interested in the pathology and the ability to do endoscopies, kind of use hand-eye coordination and therapeutic skills to make diagnoses and help people kind of figure out what's going on. And then I went to Dallas. I did my GI fellowship, at UT Southwestern. And that's really the first time I really got exposed to inflammatory bowel disease and really started seeing a large patient population there. And one of my mentors there, Dr. John Anderson, kind of really exposed me to that group of patients and the treatments and got me into sort of the extracurricular activities with IBD. I went to camp for kids with inflammatory bowel disease, which again, I got to see kids in a whole different light, patients with chronic disease where you see them in one way in the medical center, and then you see kind of a whole different person when you go to those sort of camps and support services. So I really got interested in IBD there, and sort of set me on my journey. I always thought I'd be like my parents who are private practice, solo practitioners. I always thought I would be in private practice somewhere. And here I am, 20 years later and, still at a big academic center and working on, for a large part of my career, working with really a unique group of patients and a unique disease with inflammatory bowel disease. But IBD was really interesting to me because it was that chronic disease. So it gave me the opportunity to build relationships, and I like that. I like seeing patients more than once. I like getting to know them and getting to know their families and hopefully helping them across their journey of IBD. The immunology, the GI, the medications, again, endoscopies to help diagnose, all of those things really got me interested in taking care of IBD. And then the research, so much is happening now with trying to understand what causes this disease, what's the better treatment for this disease, what's the best surgery, are there certain patient populations that are more at risk? So kind of all of those things together, I could probably ramble on forever.
You notice we're not stopping you. We're like, yes, and yes, and.
Well, and it is a huge difference between like being a primary care physician and being an IBD specialist. I mean, that is a big jump to make to go from one to the other. But I think there must be something really enticing about being an expert in something and really kind of digging down, especially since you have not only clinical interest, but research interest.
Yeah, I think it's definitely true. I mean, again, when I got into GI, it was cool because it was a bunch of different pathology. But then as I sort of kind of progressed in my career, it was for me at UT Southwestern and now here at Phoenix Children's, it was nice to kind of be identified as the content or sort of expert in that area. But I took a lot of pride in that too. I wanted to know what was going on in literature. I wanted to know, like we talked about, what was happening on the research front. And I wanted, wherever I was, I wanted us to be involved in sort of the education and the support of our patients. And so doing those things kind of in a singular disease is obviously, a little bit easier than doing it across all of GI. But it also comes with a lot of responsibility. When we train fellows, right? Then the fellows come to you because they want to ask you or pick your brain about IBD or approaches and disease and treatments. And so, it's fun, but it's a big responsibility too.
Right. It's tough to be as amazing as you, isn't it? It's just so hard.
I'm only halfway through my beer, so give me another 7 or 8 ounces.
I should have started you with bourbon. I think that we would have gotten the real you out a little bit more.
That's funny.
So you mentioned research. That is one of the things that Robin and I kind of wanted to ask you about, because there is some really cool studies that have been happening that are starting to help to identify like the path that kids will potentially be on with their disease. I mean, you were very involved in the risk study, and I'm guessing now that you've rehomed to Phoenix that you are as well. So talk to us a little bit about kind of some of these really cool things that are happening in research.
Yeah. So when I went to GI fellowship, that was 2003. So 03 to 06. And it was definitely the sort of cusp of what we call kind of the biologic era in IBD now. And there weren't a lot of treatments. We had kind of infliximab had just come to the market, and adalimumab was coming on the market. And we really treated patients very traditionally because we really had only one medication to sort of escalate, in our minds escalate at the time too. And so it was just a different approach. And so often I felt like we approached a patient that, okay, what can we do before we do something else? And now, 14, 15 years later, I think the world of IBD has really come full circle from that. And what I spend a lot of effort teaching residents and fellows is that it's not anymore about, try to hold the course and try to move slowly. It's rather about appropriate therapy for the appropriate patient. And, the hot buzzword in IBD, as well as in a lot of chronic illnesses, is personalized medicine. But what does it mean in an inflammatory bowel disease? And that's where I think it's really unique, is that it takes some real effort to understand what type of patient is sitting in front of you, what type of disease do they have? And then if you understand that well, and in your mind, if you've understood what type of disease you think they have, and you know that this is a aggressive and progressive disease without a cure, that you can start to frame what you think are the best therapy for the patient today, rather than saying, okay, we got to try this, then we got to go to this, then we got to step up to this. I hate the idea. I hate even mentioning it here. I hate the word saying step up, because it's an antiquated process that gives the impression that one therapy is more dangerous than the other. And so we're going to wait to step up to that therapy. And what we know now is that it's actually better to treat the patient with the appropriate therapy, because we have a real chance to change the natural history of that disease in that patient. And if we can do that, particularly in pediatrics, when we're diagnosing kids, the youngest kid I diagnosed was 9 months of age. Well, we're talking about 85 years of their life coming up. And so can you actually change the way their disease is behaving? And that's where things like risk, did a really nice job and continues to do a nice job, because we're still following those patients out, right? So we're still saying, okay, how do they present? What do they look like at a year? What do they look like at 3 years, at 5 years, at 10 years? We will hopefully follow that out with the support of the Crohn's and Colitis Foundation, and utilizing that research is follow it out for 15, 20, 30, really get a true natural history of the disease. And the way it looks like today in the biologic era, I hope, is a lot different than it looked like 50 years ago when you see all the old papers about IBD. And so if you really think about that and think about applying research then even further, right? So the other thing that my interest is in research is at-risk ethnic populations, right? So we were part of a study called Genesis that looked at African-American patients with IBD, children with IBD, and looked at, did they have unique genetic markers and different disease process? And we looked at, on a smaller scale, we looked at Latin American, Central American, and South American patients, Hispanic patients with inflammatory bowel disease when I was in Texas. And now another population that's interesting to me that we just had a poster at NASPGHAN about is Asian American patients with IBD, right? So this disease was classically described in Caucasian patients, more commonly of Jewish descent. And now we're seeing it affects everybody. It affects all of these different ethnic groups and populations from all over the world. And in here in the US, how is that different? That's really interesting to me. And figuring out how an Asian American kid may behave differently over the course of their disease than an African American kid or a Caucasian kid. And so that's where, this type of research to me is just fascinating and fun, because it's taking it right from sort of understanding it for a patient population and hopefully tomorrow applying it to that patient population and making a difference in an individual patient's life, even though you're looking at bigger populations.
Yeah. I have to tell you that I love listening to researchers talk about their research, especially as a patient, because you are practically jumping out of your seat right now, telling us about this research. And as a patient, it makes me so happy to see someone so passionate about really finding out what the heck is going on inside of our bodies with these diseases, and then trying to take that information and translate that into a way that's going to make it easier for me, and especially for these kids that you work with, to use air quotes normal, a new normal, relatively normal, kind of life. I was diagnosed at 25, so I wasn't little, but it was 20 years ago. And I can tell you just from my personal experience, there were no biologics on the market, or they were just coming out at that point. So through the course of my disease, I've seen significant changes in 20 years. It's crazy to me when I think about it. And then to hear you talk about what's on the cusp right now, it's going to be life-changing for these kiddos.
Yeah, I say it a lot to families that I honestly believe that inflammatory bowel disease, the bucket of inflammatory bowel disease, Crohn's disease, and ulcerative colitis is unfortunately like two big buckets, but there's probably unique features of the disease inside of that bucket that over my lifetime, your lifetime, I think we'll start to sort of pull out, hey, we call this Crohn's, but it is Crohn's-like, but this is what we should call it because of the genetics now that we understand with it. This was ulcerative colitis. It was actually a disruption of their mucosal immunity. And so we shouldn't call it classic ulcerative colitis. We should call it ulcerative colitis type B or type D or whatever it is. And when we start understanding that, then you can take that next step and be like, okay, so this group of patients best responds to this therapy, and this group of patients best responds to this set of therapy. But therapeutics are just exploding, right? And so we had this biologic era, which, unfortunately you missed. I wish you would have had a chance to keep your colon, but I'm sure you do too. But
yes.
Now we have, not only the anti-TNF, so we've got actually other like alternate mechanism of action drugs. So now we're not only just, if a TNF is not the right drug for a kid or an adult, then we've got drugs that act in different pathways, different mechanisms of action, different ways to control inflammation through the immune response. And that hopefully will continue to be better elucidated so that we know which one is the right drug for which patient. And so I tell parents that I think in your child's lifetime that we will be at a place that there are true curative therapies for your child. And I really do believe that. Even now we still do see, even in the pipeline for therapeutics, there are, again, probably 3 or 4, different mechanism of action drugs already out there. What we need to continue to push the envelope for is not only just therapeutics, but cures, right? And again, that's where, the Crohn's and Colitis Foundation is super involved. The NASPGHAN, AGA, all of our Improved Care Now, all of these collaborative works, yes, they want to improve the lives of patients. They want to help and educate, but we all want to push the needle to get to cures for some of these patients, where we're not just modulating, we're actually changing what's causing this disease, and saving people from surgery, and saving people from chronic medications that have their own set of risk and dangers and things like that. So it's a funny statement to make, maybe funny to me since I don't have IBD, maybe not funny to someone that has IBD, but I don't mean it to be funny. It's if you were to ever have IBD in the span of time, the time now, like how much investigation and new therapies and effort, and if you were to have the disease, it is the time now. It's really exciting. It's not exciting to have the disease, but exciting to really potentially have the opportunity to have a cure in your lifetime.
It is exciting. It doesn't sound funny. I've actually said that to somebody. Now's the time to get diagnosed. 20 years ago was not the time to get diagnosed. Now is the time. You timed it right. I don't know what you did, but you timed it right. So yeah.
Well, and especially Robin, in your case, getting misdiagnosed.
Right. Yay.
Yeah, and that's what happens.
That's better now too, right? Being able to diagnose people more accurately, faster. I'm assuming that fewer people are being told that it's all in their head. They just have a stomach ache, hopefully. You've talked about residency. You've talked about working with residents, working with fellows. You've done this for 20 years. So I want to ask you about the parents of the kiddos that you treat. What do you wish that they understood?
It's a great
about
question.
IBD, about raising a child with chronic illness?
So a lot of things, but I think probably when I first tell a parent that their child has IBD, probably my most effort is spent trying to educate them about the dangers of this disease. Because immediately they sort of try to take it in, kid has IBD, and then they're off onto treatments and therapies, and we're not doing this because it's dangerous, and we're not doing this because it has this side effect. And then they sort of lose track of the dangers of this disease. And I said it before, and I'll say it again. This is a chronic, aggressive, and progressive disease without a cure. And every time we think about a treatment or an option for your child or for yourself, and you think and look at the risk and side effects and concerns of X, Y, or Z treatment, it always needs to be framed against the risk of this disease. If you don't treat this disease, we know that disease phenotype gets worse. You get more strictures, you get more fistulas. You have actually a risk for colon cancer after prolonged uncontrolled ulcerative colitis. Your risk for colon cancer goes up. Colon cancer is lethal. All of those risks are significantly greater than any of the cumulative risks of our current set of medications. And that's sort of putting your mind around that and understanding that what your framework should be. Your framework should be, how do we get the disease under control? What are the best things? Not doing things irresponsibly and not minimizing side effects or risk of these medications, but understanding the true risk and side effects of this disease. That's probably, for me, the crux of the initial conversations. And then as we're talking more sort of chronically, the other thing that I really find so much value to is that, again, and we know this, there's literature out there that with chronic illnesses, we know that the rates of anxiety and depression are higher in all chronic illnesses.
Right.
Yep.
And IBD is no different.
Right.
And so you've taken a child, whatever age it is, you've taken an adult that's 25 or 45 or 55, and you've all of a sudden sort of changed their life. And maybe the adults have some better coping mechanisms. Often they don't. Or they have bad coping mechanisms.
Right.
Correct.
The kids often don't. And so, we built a psychologist that saw all of our IBD patients at every visit. And we wanted to remove the stigma of, now I think something's wrong, go see a psychologist. No, you should see a psychologist at every visit. Mental health part of this is hugely important. And we know that there's a brain-gut axis. We talk about it a lot in a lot of other diseases. Mm-hmm. It's no different in IBD. Stress, anxiety, bad mental health can exacerbate disease. So mental health, I think, is for those patients that are on it, adult or kids, adult or pediatrics. That's the one thing that I think that make sure that you seek help for the mental aspects, the psychological aspects of dealing with a chronic illness, so that you're better prepared when you have a medical problem or an issue or surgery, right?
Right.
You know, you're getting ready for this now, right?
Yes.
So I'm sure there's some stress around it. You have to think of ways that you're going to cope with that. It's just going to disrupt your life. Yes, you're looking forward to having the next step of the surgery, but at the same token, there's got to be some concern and some unknown and all of those things. And with kids, I see that super amplified, and that's again where things like camp, I think, are. I mean, it's amazing. I mean, when we go to camp and we'll do a big sort of round table with the older kids, like the 16, 17, 18-year-old kids. And we'll do a male only session and a female only session so they can get their personal questions out. And then we'll do generally a joint session. And our intent is to try to figure out ways to start making them better adult patients. So teaching autonomy and independence and those type of things. But it's amazing some of the stuff, some of the questions that generate from that. And we do it anonymous, so people aren't feeling pressured and that kind of stuff. But we always have a psychologist there, usually a child life or two specialist, a doctor. And so that you see how much often they don't get that support. And I think that to me is really, really important.
Well, I think, and Alicia, you probably agree with me, just the opportunity to ask questions of their doctor without their parents there.
Yes.
I can only imagine how much, I'm sure, especially teenagers, there are questions that they want to ask their doctor that they don't want to do in front of their parents.
Right. Yeah. Things like birth control, sexuality. I mean, yeah, there's things that you think about as a teenager that you don't want to ask in front of your mom. There's things as 40-year-olds that I don't want to say in front of my mother. So, I can't imagine trying to do that at 16. But I think it's your point about mental health is super, super important. And so I'm going to bring us back to it. And I'm going to reiterate it because there is no shame in the game of getting therapy, regardless of what's going on in your life. No shame at all. And I say this as a social worker, and so I highly encourage, in fact, I tell a lot of people to go get therapy, regardless of whether they ask me whether they should or not. And so I'm a huge proponent of that. And especially in this case, because there is something about your identity that shifts. I think when you are diagnosed with a chronic illness, you have another label that sort of gets attached to you and you can give it power depending on how much you let it. And so I think for some of our folks, talking to a therapist or talking to a psychologist and really sort of helping come to terms with this new piece of your identity and making sure that you're not letting it become the entirety of you and in a pathological way, I think is super important.
Yeah, when you talk about, particularly in our kids, like the kids that I have dealt with at camp, and you see that, normally a 16, a 17, 18-year-old kid that doesn't have any chronic illnesses, this is the time that they're really grasping for independence and that sort of, hey, I'm on my own. I can drive now, and I want to do this myself and do this myself. And often these kids with chronic illnesses, with IBD, they're robbed of that independence because their parents are so involved, rightfully so. Not that they shouldn't be, but they lose a little bit of that ability to learn autonomy and independence, and they just sort of, I've told you before at camp, I'm like, I've been seeing that kid in clinic for 3 years. And in that cumulative time, he said 5 words to me. And here at camp, he won't shut up. He's like the life of the part. I'm like, who is that kid? Like that kid has not spoke to me for 3 years. And so they get around, they having, again, not only the psychological support, like you said, but also having the peer support, I think is really important.
Yeah.
And finding that support group that is helpful to you to be able to have a sense of normalcy. I think that we hear that a lot from campers. Like they love to come to camp for a week because everybody has IBD. So they're no longer explaining why they have to go to the bathroom or why they have to eat this diet or why they have those scars on their belly. They're just around everybody that knows. And that, again, for teenagers, young adults, old adults, we all crave that sort of normalcy, that acceptance.
I know. I think that's perhaps a bit of a conundrum of especially being a teenager where it's like you want to fit in, but you also want to be unique. But
Yeah.
I think our kids with IBD, especially, like, they don't want to be that unique. They don't want to be the kid that's the only one that has it, but they still want to keep that sort of unique identity. And so that is one of the beauties of things like camp, is that it allows kids to fit in, but also fly their own freak flag. It's like, I get to
Yep.
do whatever. So out of curiosity, so you mentioned parents and being justifiably involved. So how do you help the kids with IBD and the parents gently start to let go of some of this, and start giving some autonomy to the
Yeah.
kids? Because I think that's a really important transition, and that's got to be super difficult.
Yeah. Yeah. It is really, really hard. One of the things that we started doing in the IBD clinic was said, okay, there's no right time. And it's hard to pick a chronological right time because
Mhm.
like we were talking about with these kids, their emotional age often lags behind their chronological age because of their chronic disease, right? But what we did, we said, okay, at 16, you're maybe learning how to drive, you're getting some more independence, that kind of stuff. When you come to clinic, you get put back, the MA puts you back by yourself and gives me the opportunity to interact directly with that young adult, and also starts forcing them to have a voice, right? So they're very happy to sit quietly in the corner while their mom is talking for 30 minutes. But if it's just me and the kid in the room, you can't be quiet. And
Right.
so that we just sort of picked it up. And there were parents that were like, oh, what are you guys doing? We're not, he's not ready for this. And we didn't, it wasn't a forced issue, but 95% of the families actually appreciated it because it actually gave their kids the ability to start developing that voice. And then we would bring the parents in and just rehash real quick and say, okay, this is what we talked about. And this is, are there anything else that you want to add? Is there anything else that's valuable or helpful as part of this discussion? And we would then sort of work together on the back end to come up with a plan or to have a plan in place. But it started with that child having their own voice. And I think, if you look at, again, there's good literature out there about transitions, and there's a lot of different ways to do it. I think you start introducing it 12, 13, 14 in terms of education, starting to educate the child about their disease and what they've been through and what their history is, so that what medicines they're taking. They should start knowing all of those things. And then when you get into that 16, 17, 18, in my opinion, that's when I want to start getting information from them. I want to hear how they've been doing. I want to hear their symptoms. I want to hear they've been having trouble with medication. And then by 18, which is which is the sort of self-appointed transition between pediatrics and adults, that's when we really start saying, okay, what's the next stage? Are you going to college somewhere? Are you going into the workplace? How can we start establishing adult care? And at that point, I think probably the most important thing to me at that point, at that bridge, is the idea of trust. At that point, the family and the kid has really developed a trust in you as the pediatric provider. Mm-hmm. And now you have to somehow convey that trust to an adult provider. And they don't know who the adult provider is. I say the best way to do transition would be for me to walk in the room with, Dr. Smith and be like, okay, hey, Johnny, from now on, you're going to be seeing Dr. Smith. He's the adult GI. We work together. That immediately conveys a sense of trust. Most of the time now, we say, okay, you need to find an adult provider. And in my opinion, that's not the way to do it. We actually say, okay, we've identified these adult practitioners in town who have the same interest and passion for IBD care that we feel like we do on the pediatric side. We think that you should try to see one of these 3 or 4 people. So try to find those IBD adult doctors in the community that want to sort of provide the same level of care that you're hopefully able to provide on the pediatric side. And that very specific sort of referral or recommendation, in my opinion, really helps set that stage of transferal of trust. Yeah. And hopefully they can then build their relationship, because transition to me is hugely important. There's a right setting to get your care. And when you're a 12-year-old or a 6-year-old, you should be getting your care from a pediatric gastroenterologist. When you are a 25-year-old or a 35-year-old, you should not be seeing a pediatric gastroenterologist. You should be seeing an adult gastroenterologist. We have different specialties. We have different things that we focus on. When you're a 25-year-old or 35-year-old female, maybe childbearing is important to you. talk about childbearing in front of pediatric gastroenterologists. That's the quickest way you'll get transitioned out of their clinic. We're uncomfortable with the fertility and the childbearing issues, but our adult colleagues that concentrate on IBD, they're well aware of the challenges and medications and those type of things. And then, as you transition to an adult, frankly, the way medications are developed, they're developed for the adult population first, and then typically trickle down to the pediatric population. Some drugs now are being trialed in both age groups simultaneously, but it potentially opens up some therapeutic options for you as a patient. So you should always, I think that's why transition is so important, is that you should get care in the proper setting for you. And as an adult gastroenterologist is better at the issues we talked about. They're better at colon cancer screening. I don't do colon cancer screening. We don't see colon cancer in pediatrics. That's why you should see an adult doctor. And so having those sort of resources, I think, is also really important when you talk about that transition process.
Yeah. It must be somewhat difficult too, though, because you have developed such a relationship with these families and these kids that, it's like sending your own child off to college, it's like, bye-bye, good luck in the world. And that is, I think, hard in another way too, because you have sort of your folks where you're like, I know these people really well, and I know that they sort of handle kids the way I would want them to handle, or they're going to handle this IBD patient the way I would want to handle. But it is such a personal relationship that you have with this doctor. Like you said, it's something you're going to have for the rest of your life. So you have to make sure that your relationship with your provider is something you can maintain for the rest of your life. It's like picking a marriage partner, frankly. You're going to hang out with this person for a long time. You got to like them. You got to feel like they have your best interest. But it's hard because you can't just give them a list of people and say, here you go, there are these people, good luck.
Yeah, and actually, you hit the nail on the head in terms of the doctors too. We're as big offenders as the patients are, because we don't want to, like you said, I've been taking care of Johnny since he was 6. When he turns 18, who is better at taking care of Johnny on that day?
Right.
Someone who's never seen Johnny before, or me who knows Johnny for 12 years?
Exactly.
Right. And so we tend to hold on to patients as well as pediatric gastroenterologists. But again, I think that's where having a network and having providers that you trust and building that relationship in your community and understanding who the specialists are wherever you are or wherever your patients are going. I mean, I knew, when I was in Texas, I knew most of the kids go to Texas A&M or UT Austin. So I knew adult GIs in both of those areas, but I had a kid that went to Missouri, and we found an adult gastroenterologist there in Missouri, and someone that was going up to New York and to California, wherever they may be. Again, that's where you have that network. And I think it's important to make sure that they're comfortable, your patients are comfortable, but that you're also ready as a physician to relinquish that care. You could still have that relationship. I mean, I've recently moved from Dallas to Phoenix, but I still hear about my patients in Dallas very regularly because I have that relationship, and I want to. I want to know where those college admissions ended up going and what they're doing. How the family. And again, it's not just the kid; it's the families that I know so well. And so I think it's good to sort of maintain that involvement, because your empathy or your care doesn't turn off.
Right.
But they should also be getting their treatment where they can hopefully go for the next 60 years of their life. Right. So it's not only establishing it now, but it's establishing it moving forward.
Right. Well, and I can understand hanging on to patients for a little while, just because, when they're in college, it is, typically don't stay where you went to college. And so it is kind of more of a transient place. But yeah, perhaps when they get to be 25, it's time to let them go, Dr. Patel. Just saying. Just saying. I mean, one of the things you mentioned, though, is you alluded to that at some point when you turn this magical age of 18, which means nothing except for you can join the military, and you get kicked off your parents' insurance potentially at times, or you're suddenly an adult in the law. It does open up some avenues for treatment. How has that been? So as a researcher, kids are not able to sort of get into the same clinical trials as adults. So is that frustrating? Are we seeing a shift in that? Because it does mean that there's just more limited treatment options for our kids.
For sure. I think that it has, as we've seen sort of this new wave of therapies, I think that even the FDA has recognized that as these therapies come to market, that it cannot just be an adult treatment and then eventually, we start using it in peds just based on experience or exposure, or just because the pediatric guys decide to. pediatric GI guys, particularly IBDologists, tend to be early adapters of new treatments because we take care of challenging cases, and many of our treatments are off-label. But I think what you're seeing now, both I think speaks to the FDA and speaks to the approval and speaks to these companies investing the resources in doing those pediatric trials from the beginning. I think it does become a huge benefit. In the past, it's been frustrating because typically we don't have those trials, and then we are just left to doing off-label therapy and looking at the literature, at anecdotal case reports. One person, 2 people, 3 people were treated like this, and this is how we're going to try it. And again, we did that, but in pediatrics, it still would be just as valuable to understand what are the right treatments, what are the right doses, are there additional risks or concerns that would be that might be present in this pediatric age group that's not in an adult age group. And so it has shifted for sure, and we're seeing these the newer drugs apply for early trials that even go down, and even previously some of the trials only went down to 6, and now they are recognizing that in practice we're seeing kids younger than 6 years old, so you can't just arbitrarily draw a line at 6. So now they'll go down to 2 years of age. I mean, it is a balance because the concern for the trials is that it's what the FDA and IRBs and everybody consider at-risk population, right? A pediatric population or an elderly population is an at-risk, particularly pediatrics, where they're not giving their own consent for these trials. At a certain age, they have to give assent, but they don't give consent. And that's again why actually pediatric trials are often hard to enroll for also, because the parents also to a certain extent have to feel comfortable giving consent for their child to be in a trial when there may be already approved medications out there. And so I think that most of the trials now we see are patients that have failed TNFs and now using these new medications. So I think that you hit on an important point, saying that it is frustrating because they don't have as much access as our adult counterparts do across the board. And often these resources that the drug companies are allowed to give families, the resources are built on their FDA approved indication. So you can provide all this education, this nursing support, this teaching, but it has to be on an approved indication. And so if it's not approved in pediatrics, then all of a sudden those pediatrics patients not only don't have access to the drug, but when they have access to the drug, they don't have access to all the resources that the company provides. So it definitely becomes a challenge. I think it is continuing to get better. Like I said, I've seen a lot of these newer trials really try to focus early on in recruiting the pediatric patient population. And I think that'll make a big difference as you move forward.
Well, and unfortunately, you're right. Not even just company resources, it's also insurance companies. Your insurance company fights it. So you then, as the provider and your staff, end up having to try to advocate for your patient to get the thing that is not officially approved. I'm going to back you up for a second. One of the things you mentioned as you were talking about sort of, getting involved in clinical trials is consent. You are talking about diagnosing tiny children, like 9 months old. So there's a lot of aspects of consent, including, dealing with something like a very private area for a lot of people. So this is a tough question for you because we're not just talking about dealing with somebody's nose, not something that typically people keep very private, except for nowadays with COVID. So talk to me a little bit about how do you work with little kids when you're talking about an area where typically their parents are like, don't let people look at it, touch it, get involved in it?
Yeah. So, I mean, I think that particularly early on when we're having that discussion or even early on in the clinic, I will always say, when we're doing an exam or on initial evaluation and really, teenagers know it too, but I will sort of still say it, that evaluation or exam of this area should only be happening if your parents are here in the room, that you have some sort of guardian with you. And I think it's important for those younger kids to hear that because it is such a sensitive area. At the same token, you're trying not to taboo it too much because it's going to be it's likely going to be a repetitive exam, and they're often very nervous, obviously with an external exam, or even often we have to do a rectal exam. So those type of things, I think to a certain extent is sort of teaching them why we're doing it, that they should have the appropriate people in the room when it's happening. it just gives them, it sort of educates them and gives them a sense of security when that's being done. And so that's typically how I'll approach it. As they get older, often they'll want their parents out of the room, right? And so it's almost the flip. So, in that scenario, often I will have a nurse or an MA come in the room so that they have sort of a chaperone, and they feel comfortable, even though, the guys sometimes don't want anybody else in the room. And, right. So you have to sort of, understand some of those challenges. It's why the shifting a little bit, but I think why one of the biggest difficulties in this disease is awareness. And because it is such a private issue, that often people that are struggling with it or debilitated by it don't share that.
Right.
And so back to the exam part of my job there is to obviously respect their confidentiality, but also try to educate them to a certain extent that this is something that they're going to be dealing with. And so if we can raise the awareness of it and people understand that there are a lot of people that often struggle with it silently. If people are more open about their journey, then I think it raises that awareness. And as much as we can do, educating them all along that pathway from, whether they're 3 years old or 13 or 23, it just raises everybody's awareness.
Yeah. Well, and I think honestly that there's something to be said about you being able to teach about consent in general. I mean, because you are saying like in this context, and this is how you go about it, and this is how you agree to give consent too. I feel like there is also a teachable moment along that too. Just, not as if you need something else to do in your job, but there is a moment of that.
Yeah, no, absolutely. I mean, I think, when I consent for procedures, for example, once they're 13 or 14, I know that they're not signing it, but I will be talking to them that, hey, we're going to be doing an EGD and colonoscopy. The risk of this is the risk of bleeding, the risk of infection, the risk of perforation, accidentally making a hole somewhere in your intestine. And those risks are rare. And I don't anticipate that happening, but those are the known risks of endoscopy. And moving forward, if anyone ever asks you to do something, you should ask them, what's the risk-benefit ratio, right? Like, what's the benefit to me and what's the risk to me? The same question you ask when you're talking about treatments or therapies, right? That what are the risks and benefits to me, and how can I make an educated decision? Because if you don't know those, you're just taking a shot in the dark, right? You have to understand what the risks and benefits are and why that this is the right choice for you today.
Right. I think one of the most interesting conversations and sort of one of those, light bulb moments for me was having a conversation with somebody who was an adult, but who had been diagnosed as a child and who had sort of, gone through the pediatric system. She said to me, like, she has some trauma associated with the fact that like, her body became not her own. And so, she spent a lot of her time, with people doing things to her as part of being hospitalized and as part of being treated, and I think that is hard because at some point, yes, you have to talk to a child and say, is it okay that we do these things? But at some point you have to do the thing, and the consent somewhat goes away at that point. It's like at some point you have to, like, if your child is very, 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 very sick and the only diagnostic tool you have is a colonoscopy, you do the colonoscopy, even if it's not okay for, even if the child is saying absolutely not, I don't want this, because their life is in danger at some point. So it's hard.
Yeah, it's a razor's edge, right? Like kind of being a bystander and being an active participant, and when it's okay to be a bystander and when we need you to be an active participant. I've had kids that their parents are like, okay, what other medicine can we give him? What other medicine can we give him? What other medicine can we give him? And the kid is like, take my colon out. Stop. Stop. I don't want any other medicines. Take my colon out. I'm done. And it's hard because the kid doesn't make that decision. The parents give that consent, right? And so that's where, just trying to get that balance and respecting everybody's opinion and voice in the room and giving that kid a voice and trying to help understand where they want to go or what they want to do. It's hard on the opposite side. Like, what if the parent is like, I don't want to do any medicines, just take his colon out. And the kid is like, oh, wait, there's like 3 medicines that I read about on the internet.
Right.
And, and so, part of it is sort of having a good relationship with the family and the children. I think is hugely important. It leads to less of that strife, but even in the best of intentions, there can be differing family views. There can be different parental views. Mom and dad cannot agree,
Right.
And then the kid either becomes a tiebreaker or becomes a pawn in trying to decide what they do. And so, certainly is challenging. And it's, all of the choices are, not without merit. Had early surgery to avoid any exposure to these medications that have risk. You couldn't argue that if someone is doing something hurtful to their child. And likewise, trying as many medicines as you can to try to prevent surgery, because we know there can be complications, long-term impact of surgery is also not inappropriate. So you have to kind of put, what I try to do is try as much as you can to put yourself in their position and try to understand. Some people get mad. They're like, oh, you need to call CPS on that family because they're not doing what you told them to do. And it's like, well, for me, I'm a partner in this. If this was a situation where I'm dictating therapy, there may be certain scenarios where I need to do that. But most of medicine is still an art. And particularly in IBD, there are options, there are considerations. And so you need to treat it like that. And you need to be a partner in their care, not a dictator of their care, in my opinion.
Right. Absolutely. And I think in general, you should be an active partner in your healthcare, regardless of what's going on. Do you have IBD? Do you have something else? You should be a knowledgeable, active participant, because I think gone are the days where we just sort of say, you know best, tell me what I should do. And for good reason. I mean, you should be a more active participant, but it must be incredibly difficult to be the sort of, tiebreaker or, sort of person having to sort of try to massage the conversation. Because I do think there's ways to talk to people about, you don't love these options, but these are the options, and so we do have to make a choice between these terrible options, and I've had before I'm going to put it out there, before Obamacare, I had to have that conversation with people a lot when I was a social worker, saying, here are your really terrible healthcare options. Like, you can do this thing that's really expensive. You can do this thing that's, equally terrible. And even though it's a terrible decision, it's a terrible decision. And in this case, it just may feel terrible to the person. And so, it's just kind of how you massage the conversation with that person to help them actually.
I think often they feel like every decision has a lot of finality to it.
Yeah.
And so part of it is that regardless of what we do, we're always going to be reassessing. We're going to see if it has a benefit. We're going to weigh the risk or the problems with it. We're not going to do anything that doesn't work. We're always rethinking or always trying to reevaluate. And that's, again, how medicine should be.
Right.
It is rare the case where, throw them on adalimumab and never see them again, right? Or throw them on infliximab and never see them again. There are kids that I've had on both of those medications that had, 8-10 years of great response. But it's more commonly the sort of constant reevaluation and understanding and making sure that you're on the right track that I think is important to their care. So they also feel comfortable on the track that they're on.
You're right. There is so many more options out there that it doesn't feel like a final decision. But I think especially trying to make a decision for somebody else as a parent, it must be incredibly difficult to say, yes, I'm going to make this big decision that has these ramifications and has this ripple. Because even now there is sort of a half-life for our medicines. Like, you can sort of expect to be on them for a certain amount of time before perhaps they start to lose their efficacy and you have to try something different. And so even now, like, you start down that path and then there's sort of there has to be something beyond it. And I think that must be an incredibly difficult decision as a parent, especially for somebody super, super, super young.
Yeah, for sure. And they'll say that very, very clearly that, they struggle with the idea of doing something that might hurt their kid. Right. And I immediately empathize with that concept, because I too don't want to do something that hurts your kid.
No.
But at the same token, this is where we're at. We need to actually try to help your kid.
Right.
And not be just scared by the risk. And that's where often, they start gaining that understanding. And then, as things are working, they understand that this is what's actually the road we're going down, is to try to help this child.
Right. Out of curiosity, and this is going to be a super left field question for you, so even more left field than the consent question, but looking at something like CRISPR, for instance, how close to like something like gene editing
Mhm.
are we for something for treatment, for IBD treatment? I mean, I guess there's a part of me that says this is a stupid question, Alicia, because I know there's so many genes involved in IBD,
Yeah.
but is there genetic therapy sort of on the horizon, and how close are we to that?
Yeah, I think that you answered it a little bit. I mean, I think that the difficulty has become.
The answer was, don't ask the stupid question, Alicia. Is
No, no, no.
that the answer?
Not that part of it. The part of the you identify that as we learn more and more about the genetics, that there's more, that we just keep finding more and more gene pathways that might be involved in the dysregulation of inflammation. And then which one do you correct, and which one helps the most amount of people, right? There is, it's not sort of gene therapy per se, but we know that one of the ones that we pulled out of the bucket was the patients that had very severe perianal disease. And those patients, there's a subset of those patients that turned out to have an IL-10 deficiency. And so that was identified, reported group of patients. And so now you can actually, in certain research settings, you can test, even I think now commercially available, you can test for IL-10 deficiency. Now it's, exceedingly rare. And the treatment for it is bone marrow transplant.
Oh, interesting.
So instead of, it's not like you're just all of a sudden, well, I identified this immune deficiency and I can correct that immune deficiency genetically. No, in fact, you're correcting it by doing a bone marrow transplant.
Huh.
And so you're trading, maybe chronic medications, lifelong medications, for chronic lifelong medications associated with bone marrow transplant. So I think that
sorry to interrupt you, but it isn't just one bone marrow transplant, it's continuing bone marrow transplant.
Well, no, it's a single bone marrow transplant, but typically after bone marrow transplant, then you need to be on immunosuppression to help control any reaction.
Got it. Okay. All right. Yeah. So you're immune compromised regardless.
Anyway, right, exactly. So I don't, in terms of gene therapy, I feel like we're still a ways from targeting particular gene defects that we think will help a big group of patients.
Got it.
I think we continue to grow the number of genetic defects that we think might be associated with IBD. Take the cystic fibrosis story, for example, right? We know that the vast majority of cystic fibrosis is caused by a mutation at Delta 508. And we've known that for a while, but we still haven't been able to genetically correct Delta 508. Cystic fibrosis has sort of a smoking gun. It has a gene that's commonly associated with disease in a large amount of patients. We don't have that. And so we're left with potentially trying to correct multiple genes or multiple pathways. And so I think in terms of gene therapy, I feel like we're still a ways away in the IBD story, until maybe we start picking out individual forms of IBD maybe related to a gene defect.
Yeah. Well, and I think that this is the interesting thing about autoimmune diseases, again, kind of going back to your comment to Robin about it's interesting to me, but probably not interesting to you. But I think that's the really fascinating thing about autoimmune diseases in general, is they have these big buckets. And I think there's so much, the more we learn, the more those buckets become individual buckets or smaller buckets or sort of, things we didn't anticipate. My dad had multiple sclerosis, and I can't tell you how many times I talk to people with MS saying, we don't even know if we're really looking at the same MS,
right.
Your
That's
disease progresses, you were diagnosed and progressed very rapidly to very significant disability, but other people, have had it for ages and didn't know they had it. And so are we really even looking at the same thing? And I think
what's the difference?
Yeah, that's the case with IBD as well. Like you said, I think we're, who knows if we're really even looking at the same thing. So it's super fascinating.
Yeah, I think it's going to grow. I think that space is going to grow more before we're able to actually start, weaning it down to specific pathways.
Right. Well, and even that's where those environmental factors get pulled in too. One of the reasons why both, like Crohn's disease and ulcerative colitis and things like multiple sclerosis have funding through the Department of Defense research pool is because there have been these environmental factors that get pulled in, and all of a sudden we see our service members being diagnosed with these autoimmune diseases at a higher rate. And so what about their service? What about what happened when they were in the military changed the dynamics for them, changed the sort of the way that they interact with the world, and that then introduced potentially more autoimmune diseases. So I think it's hard because that's not maybe a genetic factor, that's an environmental factor. So how do they all play together? So I think there's so much more that we need to learn, and it feels overwhelming at times, but it's exciting to hear how passionate and excited you are about the research and where we're going with it and what that means for our patient population. So thank you so much, Dr. Patel. Unfortunately, Robin did abandon us at some point, but I literally, I could talk to you forever and ever and ever, but at some point people get tired of listening to podcasts, I feel like, or they finish their walk or whatever. So thank you so much, Dr. Patel. Well, this really was super interesting, and we really appreciate you coming on to be our very first guest.
Awesome.